My talk is on the interstitial diseases of the lung, and I will have to preface this talk by pointing out to you that while on routine chest x-rays and on CT examinations, various interstitial diseases are common. In reviewing the literature, one often gets the impression that it should be possible for the radiologist to examine the images and come to a conclusive diagnosis. It is worth bearing in mind, however, that histopathologists recognize something between 100 and 150 histologically distinct and different interstitial diseases. Therefore, I will concentrate on the common manifestations of some common diseases, or diseases that I think are particularly important for radiologists to be able to differentiate. First of all, it's important to define what, in fact, is the interstitium of the lung. It is, as you see, a compartment in the lung. It surrounds vessels, contains lymphatics, and it is very important to bear in mind that this space can leak, that edema or even proteinaceous material that accumulates within it may ooze out of that space and into the alveolar units or into the pleural space. It is divided into different spaces. The first of these is called the axial interstitium, and that is the tissue compartment that extends along the bronchi and artery and along the veins. It extends from the axial interstitium into the septal interstitium. That is the interstitium that, when thick, will form the classic curly lines that we all know very well about. When one looks at the surface of the lung, these are often polygonal in architecture, and the same appearance may sometimes be detectable on the chest X-ray, or more specifically on the chest CT. When one looks at the interstitium a little more closely, what we're looking at here is the so-called secondary pulmonary lobule. The secondary pulmonary lobule is a rather confusing term because it implies that there is a primary pulmonary lobule, as there was, but the term is now largely abandoned, and we concentrate on the secondary pulmonary lobule, which is that structure of the lung, which is the smallest part of the lung that is surrounded by connective tissue. The connective tissue, which when thick will form the curly line, contains lymphatics and veins, is continuous centrally with the axial interstitium, and continuous peripherally with the interstitium that runs along the visceral pleura, which contains lymphatics. There is also an alveolar wall interstitium, which is very rarely visible with any of our technology. On the high-resolution scan, in certain diseases, the exact same anatomy can be very, very clearly seen. Here is the secondary pulmonary lobule schematically demonstrated, and if one looks closely here, one can see another secondary pulmonary lobule. The wall is thick, and the central dot in the middle is composed of either the arteriole or the bronchiole, and if it is visible, it is pathologically thickened. It is often thickened, for example, in conditions that block bronchioles, and it may be thickened in conditions that involve the lymphatics. When one looks at the periphery of the lung, it is possible to see small curly type lines, and one can see another one, for example, here. The axial interstitium, as I reminded you, involves the arteriole, or the artery, and the adjacent bronchus or bronchiole. This is the bronchus and this is the artery. You'll notice that the wall of the bronchus is considerably thickened. That is almost inevitable in any kind of axial interstitial disease, that the bronchial wall will be thickened. It is very rudimentary to try to separate a disease that we're looking at into whether it is an airspace or an interstitial abnormality. Interstitial diseases, by their character, are inhomogeneous. One can see the classic curly line, and as it extends more centrally, it becomes a little more opaque and less well-defined, but this disease process, nevertheless, is inhomogeneous, and in contradistinction to that, when one looks at an airspace disease, it is very homogeneous, and all of the air sacs are filled. This, of course, is a classic example of acute congestive heart failure, but don't be deluded into thinking that the curly B line is necessarily indicative of edema, because it can be produced by anything that thickens the structures in the wall of the secondary pulmonary lobule, the venule, the connective tissue, or the lymphatics. The morphology, it is customary to classify it as such, as linear, which may be sharp, the classic curly line, unsharp. A good example of this is asbestosis. It may be reticular, and a reticulum means a net-like structure. And by convention, these are defined as fine, likened, I'll have to say, in the older literature to a nylon, or prior to that, a silk stocking, medium, 3 to 10 millimeters, and coarse, 10 millimeters, and sometimes larger. Or the disease may appear nodular, and the nodules, for the most part, are very sharply marginated, or micronodular, very punctate things, such as one will see in some of the very earliest manifestations of silicosis, or they may be quite large nodules. The acute interstitial diseases, and I'm not at all going to make an exhaustive list of any of these things. I'm trying to deal with common diseases that commonly cross our desks. One has to think about either edema of cardiac or hypervolemic origin, or a leak. That is, the capillary interstitium, capillary endothelium is leaking into the interstitium and simulates, unless one looks very closely, cardiac edema. It can be due to a drug reaction, infections. Most of the interstitial infections will turn out to be viruses or mycoplasma, or, depending upon one's location, PCP infection, geographic location. It's very uncommon for blood to give interstitial disease acutely, though as hemorrhage in the lung is resolving, it may produce an interstitial abnormality. And then there are the non-specific interstitial pneumonias, and one of these, which we used to call Hammond-Rich or acute interstitial pneumonia, can be a fairly acute process, not only in its evolution, but in its progression to death. Of the chronic diseases, the common ones that we see, still asbestosis, and we will still be seeing this for quite a while. Silica is disappearing. Cigarettes will be with us for the foreseeable future, and the interstitial disease that is produced by cigarettes is not really fibrosis. It is due to bronchiolar plugging with mucus, and that gives us the coarse, so-called dirty chest we find in some patients with obstructive airways disease. We must always consider lymphocytic spread of tumor. We must always consider sarcoidosis. It is a relatively common disease. The frequency with which one sees it depends upon the patient population we deal with. because certain ethnic groups have a much higher predisposition to silicosis than do others. The chronic diseases, I've listed here the so-called idiopathic interstitial pneumonias. Now, the problem with the idiopathic interstitial pneumonias is that the radiologist is focusing on a moving target here. The classifications of these diseases tend to evolve as histopathology becomes more precise. For the moment, as of this year, this is the classification. These 6 diseases, idiopathic fibrosis or usual interstitial pneumonitis, non-specific interstitial pneumonitis, etc., and also included in this is acute non-specific interstitial pneumonitis that I showed you in the slide of the acute diseases, or the Hammond-Rich. On the plain chest films, these may be exceedingly difficult to differentiate, and even on the high resolution scan may be difficult to differentiate. It's very important to realize that the diagnosis of interstitial disease may be essentially futile unless one practices meticulous radiologic technique. These are 2 examples of normal individuals, and they are obviously rather gross, giving you an idea of things that can conceal or things that can mimic interstitial disease. Summed soft tissue. In the very obese individuals, it is exceedingly common to either undercall or overcall interstitial disease. If the periphery of the lung is inadequately exposed, interstitial disease may be simulated or concealed. One of the simple things one can do is look at the lateral. This is a rather obese individual. The plain film of the chest, the PA view, was confusing. When one looks at the lateral, it is perfectly obvious substernally that there is interstitial disease that should not be present in a normal individual. The lateral film can be absolutely critical in defining diagnosing interstitial diseases. Most of these diseases have a restrictive physiology. That means they reduce lung volumes. A very simple example of this is a patient who went into heart failure. Prior to heart failure, the RO marks the 11th rib. As failure develops, again the RO marks the 11th rib, and one notes the decline in volume. It should be realized, every radiologist needs to realize, that most of the time, most patients, if given an adequate instruction and time to execute the instruction, will breathe into very close to total lung capacity and do so reproducibly. There's very little variation in the standard upright PA chest X-ray volume if the patient cooperates and the technologist fires the exposure at the right time. Linear interstitial disease, the classic curly line, and the unsharp line. The unsharp line is an example of asbestosis, and for those of us who are B readers, we have come reluctantly to accept the fact that for the purposes of B reading and occupational safety and health, these are actually known as nodules. Then one finds reticular or reticular-nodular interstitial disease. This is a classic example of reticular-nodular interstitial disease, which is a matrix which may be fine or thick or coarse, and it is often reticulonodular because the meshes of the net overlap. On the high-resolution scan, the same thing, of course, is more obvious and appears more rational. The nodules of interstitial disease are usually very sharp, but not invariably. An example of silicosis and an example of miliary tuberculosis. Acutely miliary tuberculosis may be quite sharp, not quite as sharp as on this one, but as the disease evolves, they become less sharp because the membrane that surrounds them is leaky. Hematogenous metastases are, of course, at least initially in the interstitium, though will quickly spread out of it if given the opportunity. The distribution of the disease will often provide us useful clues as to its etiology. The medulla of the lung is usually defined as the most central portion of the lung, the cortex the most peripheral portion, the outer 2 centimeters or so, and the common diseases that appear in the center of the lung are edema, alveolitis, and again, depending upon the geographic location in which one practices, PCP. Cortex, classically usual interstitial pneumonitis, and these others. Sarcoid sometimes, rather curiously, will be dominantly in the cortex of the lung. Two examples of medullary distribution of interstitial disease, almost confluent, very finely nodular, as in this particular case here. The periphery spared, here again the periphery spared. This is PCP pneumonia, which quite commonly will be in this particular distribution. This is a consequence of drug exposure. It is a street drug, and one sees this with either cocaine or heroin. It is an acute interstitial pneumonia or hemorrhage secondary to cocaine or heroin use, and we see it most commonly with crack cocaine, which fortunately is disappearing in usage. Extrinsic allergic alveolitis is or allergic pneumonitis is commonly missed in my experience, because I commonly miss it, is why I say in my experience. It is a very hazy opacity. It tends to be in the center of the lung, and on high resolution CT one can again appreciate that it tends to be in the center of the lung, but its appearance varies by its severity. Sometimes there are indistinct centrilobular pulmonary nodules, and sometimes it is accompanied by a more geographic pattern with ground glass opacity, and it will appear quite distinctly interstitial on the PA as well as on the high resolution view. Non-specific interstitial fibrosis, and there is no possible way the radiologist can make a histologic diagnosis of this, will typically be a disease that will involve both the cortex and the medulla, and is quite clearly distinct from the interstitial disease, which is reticular, dominantly in the basis, and dominantly ascending along the cortex. And this is the classic manifestation of usual interstitial pneumonitis, or UIP, as it commonly is termed. This is a very important diagnosis to be familiar with. It is a honeycomb type of pattern, and the main thing that one has to recognize, it is dominantly basal and ascends the cortex, and that it is irreparable. We see a great deal of it because there is a clinical trial of a drug in our institution. This was an individual who came in to see us this week with a history of chronic cigarette smoke exposure. This is not due to cigarette smoke exposure. It is non-specific. It can be due to a wide range of provoking agents, and on examining these lesions histologically or radiologically, it is quite commonly impossible to tell what was the provoking agent. The characteristic which defines that it is fibrosis is when you see bronchi or bronchioles dilated within it. That will indicate that there is traction bronchiectasis or traction bronchiectasis, which pulls the airways apart. A very similar distribution can be seen in other disorders, which superficially are very similar. This, for example, is an example of bronchiolitis obliterans, which is commonly called bronchiolitis obliterans organizing pneumonia, but one manifestation or another may be dominant. This is dominantly bronchiolitis obliterans. It might well be usual desquamative interstitial pneumonitis extending along the periphery. On the high resolution view, one can appreciate again the cortical distribution, but it appears somewhat more nodular. All zones, there are a wide variety of diseases that will involve all zones of the lungs. The dirty chest I've already referred to, which is a consequence of exposure to cigarette smoke, and they go down through these wide variety of disorders, any of which may involve any part of the lung. Two of the commonest manifestations of interstitial disease that affect the entire lung are these. One is clearly congestive heart failure. In this particular case, it is involving both the cortex and medulla. It really couldn't be anything other than congestive heart failure, and at first sight, this looks exactly the same. The heart is big as it is on this one. However, if you look here, you will see air bronchograms. Air bronchograms are noticeable for their paucity in uncomplicated pulmonary edema. We really should suspect some other disease if we see air bronchogram in something that looks like edema. This is a patient with the acute respiratory distress syndrome, or ARDS, in its acute exudative form. PCP, again, may affect the entire lung. Again, this particular case happens to spare the periphery. A variety of viral infections, and this happens to be mycoplasma, can do exactly the same thing. And here again we've got an example of alveolitis, and another example here of PCP, which happens to be dominantly infecting the medulla of the lung. Drugs, a whole variety of drugs, extending from aspirin to chemotherapeutic drugs, may produce interstitial lung disease. This one happens to be one of the commonest. It's bleomycin. There's an immediate tip-off on this as to what the drug is. This is the antiarrhythmogenic drug amiodarone, which can produce not only interstitial disease but occasionally patchy airspace disease. And since it typically will afflict individuals with heart failure, the pattern can be exceedingly confusing radiologically. Lower zone diseases, think of common things first. Common things commonly occur. This patient, unlike most of the others, the lungs look relatively large. While I have said that interstitial disease is characteristically a restrictive abnormality, many individuals who are exposed to disorders that will give them restrictive diseases also smoke. This particular patient, if you look behind the heart, you will identify a hiatus hernia. There is interstitial disease in the basis due to repetitive aspiration, which will set up fibrosis. That must always be considered among the basal interstitial diseases, as well as the more classic things, like another example of usual interstitial pneumonitis that I've shown you, which is typically basal, reticular. We must always think of the connective tissue disorders. The textbooks will tell us that one of these connective tissue disorders can be differentiated from another by using very carefully defined criteria. I must admit that I am not able to do that. One must throw all of the connective tissue disorders into contention when there is a basal interstitial abnormality. That said, however, when it is very, very unsharp, as it is in this case, as it appears on the plain film, one has to think of something that is complicated by hemorrhage. So the vascularities such as lupus come into play. This is the high-resolution CT on the same examination, which shows what is actually almost a UIP-like pattern, and you can notice some dilated peripheral bronchi in there, indicating that as a result of this injury and repetitive hemorrhage and other injury, fibrosis is beginning to develop and pulling things apart. Lymphocytic spread of tumor may be diffuse. It may be cortical, it may be medullary. Most of the time, it is dominantly in the lower zones. This is a person with metastatic melanoma, which has gone to the hilar nodes and gone to the periphery, dominantly in the basis. While we define this radiologically as lymphangitic spread of tumor, in actual fact, most of these metastases reach the lung through the bloodstream and just elect to grow up and down through the interstitial planes. Hence, they tend to be dominant in the basis. Here again, we will see thickening of the septal interstitium and the septal interstitium coming centrally. In some areas, we will find thickening of the axial interstitium, narrowing the wall of a bronchus. Mixed connective tissue disease looks much the same as the interstitial lung disease of rheumatoid arthritis. They both tend to involve the basis. Mixed connective tissue disease is the only one of these diseases that I have seen produce an emphysema-like abnormality in the upper zones. Many of these diseases will be associated with pulmonary artery hypertension. You will notice that the main branch of the pulmonary artery is as big, or if not bigger, than the pulmonary artery, which is a very reliable sign of PA hypertension. Dr. McMahon referred to this particular condition, so I'll gloss by it very quickly. I'm sure this is Mycobacterium avium intracellulare infection in an immunologically normal adult individual with obstructive airways disease. We're seeing more and more of this as we look for it. It is not restricted to any particular class in society. There is a tendency for it to involve older individuals with obstructive airways disease, but we have seen it in very upright, middle class, highly respectable individuals who were deeply insulted when the diagnosis was established. It is very, very indolent. It is associated with chronic cough, and it must always be in the background of your differential when you find lower zone interstitial disease, particularly involving the middle lobes, associated with nodularity and bronchiectasis. It is treatable with difficulty. Upper zones, I'm only going to show a few. We occasionally are very surprised by finding adults presenting for the first time with cystic fibrosis. And the disease is characteristically, of course, large lungs, and often dominantly an interstitial abnormality in the upper lobes where the bronchi are thickened. But as you can see, there are a variety of other disorders, and many, many more are listed in the classic list that we all refer to. I've listed here, more for nostalgic reasons than anything else, the association of ankylosing spondylitis with upper lobe fibrosis or upper lobe interstitial disease. I say for almost nostalgic reasons because I've been looking for a case of this for a number of years. Haven't found one, despite the fact we have a very busy rheumatology clinic. In the rheumatology literature, it is said to occur in about 1% of cases, but in all of the radiologic differential diagnosis, it is listed. Finally, always with interstitial disease in the upper zones, sarcoid has to be considered. This is an example of sarcoid. And the last case I will show is an individual who has a mild and non-specific interstitial disease, which turned out to be a non-specific interstitial fibrosis on biopsy. There is a scar-like abnormality in the upper lobe. This scar-like abnormality is a primary lung cancer. Any interstitial disease that is associated with fibrosis, independent of exposure to cigarette smoke or no exposure to cigarette smoke, is a risk factor for cancer. Whenever you see anything that is slightly deviant, such as this scar-like abnormality here, lung cancer must be in your differential diagnosis. So in conclusion, the disease is common. The diseases we make much about, these are the usual interstitial pneumonitis, like UIP, nonspecific interstitial pneumonitis, VUP, etc. These, despite the frequency with which we read about them in the literature, are uncommon. Their incidence in the population at large varies between 1 and 200 per 100,000 of the population. Most of the time when we are looking at interstitial diseases, we are not looking at one of the so-called idiopathic interstitial pneumonitis. Pay attention to the common things. Thank you.
I think this is a hot topic, although most of us have been doing this for quite a few years now, but the technology is evolving and experience is evolving. And I'd like to review some of the issues in diagnosing pulmonary embolism. As we all know, it's a common disease, and it's one that clinicians get very nervous about because it's difficult to diagnose and it can be highly lethal, commonly found unsuspected at autopsy. The chest X-ray, of course, is very non-specific. It's not entirely useless, and I'll just, before we get into the CT findings, let me show you a couple of examples where the chest X-ray did have some interesting findings. This is a patient who came in acutely hypoxemic and short of breath. And at first glance, I think the chest X-ray is perhaps unremarkable. If you look closely at the left hilum, it looks a little strange, and come back to why it looks strange. It's not perhaps particularly large. It's a little sharply defined, and perfusion in that left lung looks decreased compared to the right lung. Here was a previous chest radiograph that shows a relatively normal-looking left hilum, and here they are side by side. So the overall size of that descending pulmonary artery has increased, and it's rather sharply defined with an area distally that has decreased perfusion. So although that's not specific and the chronicity is difficult to tell, that should raise our level of suspicion. And indeed, this patient did have massive and extensive pulmonary embolism. He had it, as you can see, on both sides. I don't know why that left hilum looked particularly abnormal, but certainly this is a very classic acute pulmonary embolus. And in fact, as we go down through the lungs, we can see the extent of that PE. So this is one of the things that we can look for, is an abnormal hilum that has become more prominent and has got decreased perfusion distally. Another finding that I think is even more suggestive is shown in this case, which we saw recently. And this chest radiograph came to us from the emergency room and had not been suggested as a case of pulmonary embolism. I think it was suspected as being pneumonia. But the findings here are small lung volumes and just a lot of streaky opacities that, particularly on the lateral, look rather more like atelectasis than pneumonia. There's also blunting of the angle, which would suggest a pleural effusion. So while infection could look like this, aspiration could look like this, in a patient who's short of breath, acute symptoms, this should really raise one's index of suspicion for PE. And just based on this, we actually suggested doing a CT scan. And as we start up from the lung bases, as we do with our protocol, we run into a lot of just streaky areas of subsegmental atelectasis, as we saw on the chest radiograph. But as we get up to the hilum on the soft tissue windows, you see a very clearly defined embolus in the right descending pulmonary artery. Incidentally, there is a dilated fluid-filled esophagus, which would make one concerned also about the possibility of aspiration. But we do have a pleural effusion, and we do have distinct evidence of distal embolism, emboli hanging up at the bifurcations of the smaller vessels and extending further distally, and seen here in profile. So this certainly confirmed our suspicions, and the chest X-ray can suggest the diagnosis. On the other hand, it's often normal, quote unquote, in the sense that in retrospect you can usually find something, but that doesn't help very much trying to make the diagnosis prospectively. Certainly basal atelectasis, these subpleural opacities due to hemorrhage or infarct and effusions, particularly in someone who doesn't have any underlying disease, who's suddenly got acute symptoms, are always suggestive. We talk a lot about oligemia and Westermarck sign, and I've shown you one example, but I must say, prospectively, it's not very often reliable because decreased perfusion can often be due to emphysema and other kinds of chronic diseases. So it isn't often that we're able to use that sign alone. Fleischner's sign is enlargement of the central pulmonary artery, and I think we did see that in the case that I showed you initially. And sharp definition of the pulmonary artery has been described, actually, and I think that that first case epitomized that finding. Presumably, that's decreased pulsation due to distension of the artery with a thrombus. Now, of course, you can do CT angiograms using single-slice helical CT, and indeed we've done it for many years before we had multi-detector scanners. It just requires a bit more patient cooperation because it takes longer to get through the chest at reasonably thin collimation. Mostly in that mode we've used 2.5 millimeter collimation. On the other hand, with multi-detector, whether it's 4 rows or more, we're in a position to routinely use thin collimation in the order of 1 millimeter. Multiple studies have shown that thinner sections are definitely better for diagnosing pulmonary embolism, all other things being equal. So we would now, by preference, use a high-speed, high-resolution protocol with 4 cc's of contrast per second. Pulmonary angio is still officially the gold standard, but in practice, pulmonary angiograms are done very rarely now, certainly in our institution for pulmonary embolism. It has got some morbidity, and although the mortality is quoted as being around 1%, in practice, I think it's safe to say it's much less than that, and there is at least one report of a series of up to, I think, 2,000 consecutive cases without a single death in one well-known institution. So it is a safe procedure. I think the practical issue has been its high cost, the necessity of bringing in a radiologist in the night to do it, and so forth. So certainly CT has been embraced by clinicians very rapidly for multiple reasons. VQ scans are not totally obsolete for this application. The situations where a VQ scan can be useful is if one has a normal chest X-ray and low clinical probability and low suspicion, but a desire to exclude pulmonary embolism. A normal VQ scan will exclude pulmonary embolism or significant embolism pretty reliably. So the prevalence of PE in that particular population will be 4% or less based on the PIOPED study. On the other hand, when you have a high probability and high clinical suspicion, a VQ scan can also apparently be quite accurate. The problem is that the majority of cases tend to fall between these two in terms of the findings on both the chest X-ray and the level of clinical suspicion. So an indeterminate result tends to be very likely from a VQ scan. Again, the technique that we use for CT involves as thin collimation as is practically feasible with the scanner that you're using. So on multi-detector, use 1 millimeter. On a single row detector, use in the order of 2.5. Still can be very diagnostic. We had used 3 cc's per second for many years, but have increased to 4 cc's and find that we haven't really any significantly increased extravasation and do have better opacification. I think that's probably the most common injection rate to use, approximately 120 to 150 cc's. Very important, the injection continues throughout the scan. The moment the forward pressure ceases, the opacification will tend to drop. Most scan from the lung bases upwards, because if the patient holds their breath for only part of the scan, the lung bases will be captured during the breath hold, and that's where the motion is. Breath hold or quiet breathing, I think that failure to hold breath is worse than just breathing very slowly and quietly, and it's certainly worth working with your technologist to achieve the very best technique for breath holding. Using hyperventilation, if the technologist how to understand how to do it, I think can be very helpful too, because it decreases the drive to breathe during the scan. Let's look a little bit at the findings and how they appear on CT scans. Classical saddle embolus, seen at the level of the pulmonary artery, and Of course, this is now a relatively common finding that we do so many CTs for pulmonary embolism. We find this surprisingly commonly, occlusion of the descending pulmonary artery here. This is not difficult to diagnose, and indeed it could be done with certainly 5 millimeter or more collimation, and we do pick up these large emboli incidentally on many of our CT scans, particularly in oncology patients. On the other hand, if we want to pick up segmental or subsegmental emboli, we need to have rather thinner collimation and more optimal vessel opacification. So here we are in the right lower lobe, and of course the way to interpret these scans is on a workstation using sequential images, which are viewed in this way. So here we are passing down into the subsegmental branches, and here we're already encountering a filling defect very clearly. Another one appearing here, a very classical acute embolus with a ring of contrast and a central defect. And here we're at a bifurcation. So in a cooperative patient with a good opacification, we can see subsegmental emboli sometimes quite clearly. In patients who have a lot of disease and consolidation, as shown here, it can be more difficult, though we can on occasion pick up small emboli even in these distal consolidated and collapsed areas in the lung basis. So notice that in this particular case we're picking up a filling defect here in the descending pulmonary artery. Here it's extending a little serpiginous thrombus extending over the bifurcation. Here it's now in both branches, and as we go down distally we see it further. Usually we don't use off-axis reconstructions. Perhaps when we have it built into our workstations we'll use it a little more often, but in all the work that's been done on PE, I don't think anyone has really shown a diagnostic advantage for using off-axis reconstructions when the readers are experienced. In our early experience, we did it more often, and certainly it can be a teaching tool. So here's an example where we've got a relatively small embolus in the left descending pulmonary artery. It perhaps could be overlooked or mistaken for an artifact, but when we go off-axis and produce an angled reconstruction, we can nicely lay out that thrombus as it extends into a branch of the pulmonary artery and make it much more unequivocal. MIPS, maximum intensity projection images are also helpful for this. So depending on what software you have on your workstations, it can be worth playing around in difficult cases. The patients at greatest risk for pulmonary embolism often are those with underlying cancers and tumors. Here's a patient with an obvious lesion in the right upper lobe and large pulmonary emboli shown on the left side here. This is an example of where one can see it laid out in a vessel in profile. Most commonly we diagnose emboli in cross-section, and that's probably the most reliable way to do it. And one has to be a little bit careful. I'll show you some pitfall examples later of where an overlapping bronchus, particularly where there's motion, can simulate an embolus. But when one has a sharply defined vessel like this, it's pretty clear that thrombus is extending throughout. Same thing here in the anterior segment of the right upper lobe and in the left descending pulmonary artery. And then more classical appearance as we get down into the lower lobe with multiple central emboli with contrast partially surrounding them. And this suggests an acute embolus. This patient also has metastatic disease in the liver. Again, the coronal and sagittal reconstructions are sometimes nice, more as a teaching tool. This patient has a very extensive large embolus here, but the interesting point is that this patient had a very nice Hampton's hump, as it's called, which is an area of consolidation due to hemorrhage and infarction, probably actually rather more hemorrhage than true infarction. We can see the embolus here. So this is just a nice demonstration of the combined finding that one can achieve with a reconstruction, and shown here in cross-section. Now, certainly you can use findings like this on a CT scan to direct your search for pulmonary emboli in the relevant parts of the lung, but these findings in themselves shouldn't be used as a criterion to diagnose pulmonary embolism, because there is nothing entirely specific about that kind of subpleural consolidation. It could be seen with infection, organizing pneumonia, and so forth. This is another patient that did have documented pulmonary embolism. You can see a part of it here in this upper lobe branch, and had a very nice example of a Hampton's hump, though not one that would so easily show on a chest X-ray, but it has that broad pleural base. It has a convex margin pointing towards the hilum, and here you see it on the lung setting, and again this was an area of focal hemorrhage and infarction. The reason I'm showing you this is we had an opportunity to follow this patient over time. This was in, I believe, November. This next scan here was about 3 months later, and here we see how the so-called ice cube or melting ice cube sign that's been described in pulmonary embolism occurs with a shrinking solid opacity, as distinct from, for instance, pneumonia, which would tend to break up, become aerated, and gradually more transparent over time. This also highlights how an infarct can look very like a lung cancer. I think if we stumbled on this when we were looking for something else, we would regard it as a suspicious lesion that might require biopsy. So if it is subpleural like this, it may be worth just waiting a little bit and seeing if it resolves, as an infarct will. This is a scan done another 3 months later. Now we're down to almost a little scar. So very nice typical progression of resolution of an infarct. So the findings we're going to look for are going to be intraluminal filling defects, cutoffs, and dilated non-opacified vessels. Acutely, vessels affected by PE do tend to dilate. Most of the work on the sensitivity specificity of CT was done now several years ago in the 90s, and it's pretty well established that CT is the way to go to diagnose pulmonary embolism. Not just in terms of pure sensitivity, but in terms of other things, negligible mortality, most particularly the potential for showing alternative diagnoses, and I'll show some examples of this. And I think this is one reason it's become so very popular with our clinicians, is that we will often be able to determine the cause of the patient's symptoms from the CT scan. This is adapted from an article by Dr. Goodman. So, putting together all of the recent series, the sensitivity has been described anywhere from 53 to 100%, and the lower sensitivity numbers date from the earlier days when people were using thicker sections and even hard copy for interpretation. But generally, it tends to be in the area of 90%, which is about as good as most tests will get. And the specificity, particularly if these criteria are applied correctly, there's always potential for over-reading of CT scans, and I'll come back to that. I think it's very important that we adhere to strict criteria. If it's not diagnostic, we call it non-diagnostic. But if it is diagnostic and we adhere to those criteria, if we call a pulmonary embolus, the clinician can be certain it is a real embolus. I talked about the benefit of alternative diagnosis. Here's an example. This was not suspected on the chest X-ray. We have a large loculated anterior pneumothorax in this patient that was being ruled out for PE. Interestingly enough, he did also have pulmonary embolism. And this is a different kind of problem, in that pulmonary embolism, we're realizing, is a very prevalent disease, especially in patients with underlying malignancy. So knowing what the significance of a small embolus is sometimes difficult. Another example of a patient coming into the emergency room with symptoms suggestive of possible pulmonary embolism does have a dense and large hilum, should make one suspicious. This is enlargement of a degree greater than one might expect from just PE. One might suspect that there's decreased perfusion in that lung. On the CT scan, not only do we have bilateral pulmonary embolism, but we have a large mass, which is a primary lung cancer with associated partial atelectasis and consolidation. So just another example of how we can pick up incidental findings that are not suspected initially. This is quite a recent case, and I think you'd agree this is a good example of a pretty normal chest X-ray, both PA and lateral. This patient just had some chest pain, as I remember. We did a CT to rule out pulmonary embolism, which tends to be the way that these things go in the emergency room. And we just found this little patch of ground glass opacity, which is just anterior to the major fissure here in the middle lobe. And I don't know what this is, but the scan was of good quality. There was no sign of pulmonary embolism, and I suspect that this was probably just an early pneumonia, perhaps even a viral pneumonia that was causing some pleuritic chest pain. This is the kind of thing that, of course, is completely undetectable on a chest X-ray in that location. How can we tell if it's acute or chronic? We can't always tell, but sometimes we can suggest it. So in chronic PE, you're going to see recanalization or sometimes organization and calcification. Intraluminal webs and bands have been described. They're hard to detect. You can get stenoses long-term and end up with pulmonary hypertension. You can see collateral vessels, mosaic perfusion, certainly, and even bronchiectasis. And some of these findings we can pick up. Here's a portable chest X-ray, a patient with fairly massive cardiomegaly, clearly large central left pulmonary artery and suggestion of less perfusion in the right lung, though the patient is very obese. We scanned this patient to evaluate for PE. In addition to the cardiac abnormalities, we have an enlarged right pulmonary artery, and you see we have soft tissue density around the lumen, which is irregular. This is very suggestive of a recanalized thrombus in the right pulmonary artery. As we go further distally, we have got bronchiectasis, another finding that's been described in pulmonary embolism. Notice that the size of the vessels is markedly decreased at this point distally compared to the left side, where the arteries are actually enlarged, related to pulmonary hypertension. But the size of the bronchus isn't really enlarged relative to the decreased pulmonary artery, and in an absolute sense, the bronchi are also enlarged. Again, this is a sign that has been described in chronic PE. And in the upper lobes with narrow windowing, we can appreciate that there's a degree of mosaic perfusion, also a sign described in chronic pulmonary embolism. Decreased perfusion in these areas relative to the more opacified areas of the lung. Again, mural thrombus, stuck to the wall, recanalization, very typical of chronic thrombus rather than acute embolus. Here is an example of a patient with cardiomegaly and a large left pulmonary artery. On the CT scan, we have a large thrombus extending into the main pulmonary artery. However, as we go further distally and we go to the descending pulmonary artery, we've really just got a very small sliver of a fibrous band. The descending pulmonary artery has essentially been obliterated, and this strongly suggests a chronic, long-standing process. In the case of acute pulmonary embolism, the artery would be dilated. But over time, with chronic thrombosis, it will shrink and fibrose, and we'll end up with this kind of appearance. Let's look at some of the pitfalls in diagnosing PE. One of them that's worth mentioning, even though many of you, I'm sure, are using soft copy now for diagnosis, is attempting to do PE studies using hard copy. And of course, if you don't have a PACS, you may not have any choice about this, but I think if you are in a hard copy situation, it's important to try to read the PE-CTs on even the CT workstation, on the QA workstation, rather than doing it entirely on a hard copy, because you really need to be able to window and level these individually depending on the degree of vascular opacification. Here's a case in point. There is an embolus here, but let's focus on this pulmonary artery, which is totally opacified. At this window, there's nothing visible there. As we window it down, using the workstation function, there is a defect here, and this is not just a streak artifact, because I can tell you lower down it became rather more obvious this was a pulmonary embolus. So one always needs to window these arteries to the point at which they're gray enough that one is going to be able to appreciate a filling defect rather than they're being totally saturated. Here's another compelling example, I think. Patient with pretty poor opacification, large heart. I believe it was a sickler, increased circulating blood volume, in which case they often tend to have poor opacification. This posterior descending pulmonary artery branch is relatively distended and perhaps a little less opacified, but not enough to call. But this is where we can use that windowing function, narrow the window. That same section shown at a narrow window, it's very clear that that artery is not opacified and that the others are. So this is actually an acute embolus that can be easily diagnosed with appropriate windowing and leveling. Another pitfall that we sometimes stumbled into in the early days was using the lung reconstruction algorithm, which is an edge-enhanced algorithm. Every vessel looks like it has an embolus when you use this algorithm because it does edge enhancement around the edge of the vessels. It looks like there's a defect in all of these. So when you see this noisy appearance, be aware that you're on that lung reconstruction algorithm, which many of the vendors promote for reading the lungs. But if you go to the standard non-edge enhanced algorithm, you'll see that the vessels are in fact completely opacified, and that's entirely an artifact. So the lung algorithm is certainly good for looking at the lung detail, but for reading defects in vessels, standard non-edge enhanced algorithm is the way to go. Vascular bifurcations can give you false positives. Here's the kind of thing might cause a problem. This is an older scan showing what looks like a defect on one section. On the next section, it's apparently that this is a trifurcation. So one never reads an embolus on a single section. One needs to look at a sequence of images and try to build a three-dimensional image in one's mind of what the anatomy actually is. We actually had a nice recent example of a potential false positive from this, from our abdominal section using 7 millimeter collimation, perceived a defect in this pulmonary artery. And I'll show you the sections above and below using 7 millimeter collimation. Well, it's clear that there's a certain amount of vascular branching going on, and one would wonder if this might be an averaging artifact. And indeed, using 1 millimeter collimation and a dedicated scan, although the opacity is a little less, I think you can very clearly see that we're looking at a little bit of fat between the superior pulmonary vein and the pulmonary artery right here, which is simulating a defect. Very clear what the actual anatomy is using the thinner sections. Motion artifact, we have a continuous battle with trying to reduce motion in patients. These patients are all short of breath. They tend to be difficult in terms of achieving a good breath hold. It can create all kinds of artifacts. This kind of thing here is very suggestive of motion and averaging. Don't call this kind of thing pulmonary embolism, especially in profile. One of the best solutions is to view the lung windows. Anytime you have a problem, look at the lung window for the same level. Very apparent that we have a bronchus overlapping and being averaged into this vessel in the z-axis. As the patient breathes, the lung moves up and down. We average the structures above and below into those vessels. Another typical example, not apparent on the single image here that this is an artifact, looks like a defect in this vessel. Here it is. Here's the lung window. We've got a bronchus crossing over there. Here's the lung window of the next section. Bronchus crossing the vessel, being averaged into it, producing an artifactual opacity. Again, this is less likely to happen using very thin sections. This would have been at 2.5 with a little motion. Rapid scanning and thin sections are the way to go. Another kind of a motion artifact might be mistaken for mural thrombus or an unusual kind of dissection, but in fact, this is pulsation. You see the same thing happening in the aorta. Don't call this an aortic dissection. This is a pulsation artifact. Bronchiectasis, ectatic bronchi can fill with mucus, get what look like non-opacified vessels, but of course there are too many here to be vessels. We know that this is the artery, the bronchus should be beside it, and sure enough we see some air in the bronchus here. And again, the answer is looking at the lung settings, looking at the air in those thickened, dilated bronchi, and perceiving that they're actually filled with mucus. So don't be tricked by bronchiectasis. And of course, lymphoid tissue at bifurcations, especially in this patient with metastatic tumor. Yes, there is an embolus there, But this, of course, and this is lymphoid tissue, and at small bifurcations this can also be tricky sometimes. Poor vascular opacification. Timing is sometimes an issue. On patients with cardiomyopathy, slow circulating blood volume, one sees the contrast is still on the right side of the heart. Very little has got through to the left atrium, and we have a non-opacified vessel here. Well, one always should follow a completely non-opacified vessel to the heart, and this is in fact a pulmonary vein which is not opacified. The contrast is still in the pulmonary arteries. An extreme example of slow circulation time, which hopefully you won't encounter very often. We've got contrast fluid levels in the heart. This, of course, is a patient who arrested in the scanner. There's no cardiac motion, so of course we're seeing the separation of the contrast in the blood. What to do about non-diagnostic exams? There are a number of causes for this. Obesity is a constant problem. We use maximum MA, and sometimes in the past I've used thicker collimation. I'm not sure that this is worth doing. I still have this slide, and some people recommended this, but although it reduces noise, I'm not certain it makes the exam more diagnostic. My tendency now is to stick with a thin collimation and try to read through the noise. And there's a temptation to overread a non-diagnostic exam to say something like it's grossly normal. And I strongly recommend against that policy, because in that situation your exams are no longer very reliable. And we try and draw a line between what's diagnostic and non-diagnostic. If it's non-diagnostic, the clinician can decide to do a scan, to do an angiogram, depending on their level of suspicion. If you say it's grossly normal, it will tend to be translated into a negative scan by the time it gets to the chart or the attending physician. So we have to be a little careful. We will sometimes say that there's nothing visible in the central pulmonary arteries in the body of the report, but in the conclusion we'll say it's non-diagnostic for pulmonary embolism. This is extreme noise at the shoulder level in an obese patient. Here we can actually detect that there is central pulmonary embolism. But obviously, in many such cases, you won't be able to see the segmental or more distal vessels. Contraindications: high serum creatinine, contrast allergy, no venous access, inability to cooperate. So in these situations, consider an alternative like a VQ scan. CT venograms are still a bit controversial, because although we do pick up DVT, in most such cases it's positive for PE. The number of cases where it changes treatment is not very high, but it is easy to do, and it just involves obtaining extra sections 2 to 2.5 minutes after the injection, pelvis through the thighs with somewhat thicker collimation, and at intervals rather than helically, principally to reduce radiation dose. And here's an example where we've achieved pretty good opacification of the veins, artery and vein at the level of the groin. Here we see a typical thrombus, partly outlined by contrast. The vein is distended. And here again, a very typical example of a thrombus. The commonest issue here tends to be, when is the exam diagnostic? Because it's impossible to predict the amount of opacification. This looks like there's no opacity, and this is the same window we used on the lungs. The answer is you almost always have to window these exams down to a narrower setting. This is the same section at a narrow window setting. Here you would say it's non-diagnostic. Here you have just enough opacity, I think, that you can say that there isn't any DVT at that level. So another argument for using a workstation routinely, and don't be filled by a fatty lymph node, which is a common finding at the hilum.
My talk will be on the airspace diseases, and as with the talk on interstitial diseases, I'm going to commence at the very beginning by defining what an airspace disease is and why it is that it looks the way that it does, and hopefully how one may differentiate among these things. By definition, the airspace is that portion of the lung which contains gas and excludes the interstitium and the purely conducting portion, that is the bronchi. An airspace abnormality is anything that replaces the air within the alveoli, filling the alveoli to a greater or lesser extent and producing a more or less homogeneous opacity. The airspace is the acinus, or collections of acini, and one of the major characteristics of these airspaces, and one of the characteristics that accounts for the characteristic radiologic abnormality that airspace diseases produce, and the problems that arise from an attempt to classify them, is these little holes in the alveoli. Now, these are the classic pores of Kohn that we've all become accustomed to. They're approximately the size of a red cell. They're about 7 or 8 microns in size, which is relatively large in the great scheme of things when one deals with small structures like this. However, we also have to remember that as we grow older, we get other holes in our alveolar wall called fenestrations. And again, in the scheme of things as regards alveoli, these can be really gigantic. They can be many times the size of a pore of Kohn, and it is for that reason that any disease in an alveolus tends to leak from one alveolus to another. The building blocks of alveolar disease consist of the fact that when it begins, it is a nodule, that is the acinar unit, and it is about such and such a size. It is about 4 to 10 millimeters. Because of these holes, there is a tendency for disease in one alveolus to leak into disease into the adjacent alveoli and opacify them. And for the same reason, airspace diseases are unsharply marginated except where they abut on a pleural surface, either the pleura peripherally, of course, or a fissure. The basic nodule has various subclassifications, and it's not necessary to get into the details of these, and I illustrate them just for completeness' sake. They have been defined as being acinar, of 4 to 10 millimeters, poorly marginated, containing air collections, subacinar, a little less disease in the acinus, and spoke wheel with these various definitions. This particular individual who aspirated barium, one can see a distinct acinar opacity where the acinus is almost entirely filled with the barium, and lesser degrees of filling, that is the subacinar and spoke wheel distributions, are present elsewhere. A classic example of the airspace nodule in someone who was prematurely extubated, made a frantic effort to take in a deep breath, profoundly reducing intrathoracic pressure, sucked alveoli out, sucked water out into the alveoli, and we see these small and very indistinct alveolar nodules. If we had taken an X-ray 15 or 30 minutes later, these would have become more coalescent. And when one might not have recognized this nodular opacity, which in real life we don't see very, very often at all. In someone with bronchoalveolar cancer, one can see also some alveolar units, this one almost entirely filled, others filled to a lesser degree with what I might call bleeding from one to the other. That is because of the leaky characteristic of the airspace. As the disease evolves, we get a situation where the nodules become almost invisible. We can see some which have become coalescent and become quite large nodules. And as the content is oozing out of them, we get incomplete filling of adjacent alveolar units, which is, for all practical purposes, not distinguishable from interstitial lung disease. The question of consolidation comes up repetitively. Clinicians in many institutions, and most certainly in our institution, will refer to all lung diseases as infiltrates. They will occasionally refer to them as consolidation. Radiologic consolidation, I think, can be fairly well defined as an airspace opacity, and extending through it, one can recognize air bronchograms. This is consolidation in the sense that when the clinician goes through the classic maneuvers of listening and percussing and doing all of these other ritualistic things that they pretend to do before they get the chest X-ray, they will find on this that there will be dullness and percussion, and because we have this consolidation with patent bronchi, they will also hear tubular breathing and all of these other things that please them. We know that you can opacify an alveolar unit and also opacify the bronchi that go through the affected region. That is quite common in bronchopneumonias where there is hemorrhagic edema of the bronchus, and in those patients it probably is not appropriate to refer to it as consolidation because the tubular breathing, etc., may not be evident clinically. There are many diseases, and this is the classic definition of the diseases that will produce an airspace opacity. There is what is loosely called water. There is what is loosely called pus, or perhaps more correctly called exudate, blood, which can result from any of a variety of diseases. Vasculitis is a very good example of that. Good pastures, thrombocytopenia. In practice, in one's day-to-day clinical practice, the two I've listed on top, vasculitis and good pastures, are actually quite uncommon. And at least in institutions like ours, where there is a large oncology group, thrombocytopenia is probably the commonest cause of blood in the alveolar units. The leukemic individuals, every leukemic individual who has come to autopsy in our institution for the last 20 or 30 years, I review all the autopsy reports, has had blood in the lungs at the time of death. Cells may be primary or metastatic tumor, and protein is a rare cause, alveolar proteinosis. Come back to the airspace disease, cardiomegaly, congestive heart failure, hypervolemia, very common. Capillary leak may be indistinguishable. They are both edema. Congestive heart failure and hypervolemia and capillary leak are both edema. It is just that capillary leak is a high protein edema and doesn't shift very much as one changes the patient's position. There are a huge variety of drug reactions that will produce both airspace and interstitial disease. I referred in an earlier slide to upper airway occlusion. Premature extubation is probably the commonest cause of edema from that reason. Strangulation we will see occasionally, and that can be intentional or unintentional. And aspirate. Now, about aspirate, I will have to remind you that the airspace opacity that we see with aspirate is not necessarily the aspirated fluid. For the most part, it is the capillary leak that recurs as a consequence of the aspiration. And some aspirate is more likely to produce leaks and more likely to produce leaks quickly than others. The rapidity with which aspirate will produce conversion of an X-ray, that is turning the X-ray white, is very dependent on volume and on the pH. If we aspirate a volume of about 50 to 100 cc's with a low pH, as one would find with a young patient, a pH of something like 1.5 or 2, the lung will convert, that is, turn white very quickly. Two classic examples of airspace disease. The alveoli are flooded, more or less homogeneously. As one extends centrally, it becomes less and less opaque. That is, that the fluid is leaking from these alveoli into these more centrally. It is only sharply marginated where it abuts a fissure or the periphery of the lung. Another very similar and almost undifferentiatable from this one is only different in the sense that the fissure is displaced cranially, and if one looks closely, the fissure is slightly bowed. This is a classic example which has been recorded for more than 2 generations in the radiologic literature of a lung cancer. It is only unusual in that this happens to be a bronchoalveolar cancer, and they typically do not reduce lung volumes. So an example of a fluid, pus in this case, or exudate, and cells producing airspace opacification. As with interstitial disease, the medulla or the cortex may be dominantly involved, the upper zones or the lower zones may be dominantly involved, and the distribution of the diseases that can produce these are listed in the slides. And there is some overlap, as you will have noticed, between these and the slides I showed for interstitial disease. Hypersensitivity pneumonia, I've listed, sometimes produces airspace disease. It is more often interstitial. Pneumonia, quite often, if one happens to intercept them early enough with the X-ray, will begin peripherally. Eosinophilic infiltration or eosinophilic opacification of the lung will typically be peripheral. Some diseases have a predisposition to involve the upper lobes, some the lower, and some will appear in all categories and can do whatever they choose to do. Now, 2 examples of edema that are rather different in appearance. They both happen to be predominantly medullary. Airspace edema happens to be dominantly medullary. This is what one usually sees. It is rather inhomogeneous. It is rather patchy in some areas, clearly airspace disease. In other space, there is some room for argument. Curly lines don't show very well on this slide. When one sees edema that is very, very opaque and very central, at least in my experience, there are 2 conditions that are most likely to do this. This is acute massive volume overload or acute pump failure, acute myocardial infarct. With acute myocardial infarct, 2 factors come into play in the flooding of the lung. One is the pump failure, which causes the edema, and the other is the fact that with acute myocardial injury, the heart releases a myocardial injury factor which actually produces a capillary leak. So you have a summation of 2 effects that lead to opacification of the lung, and it can be very, very dramatic. Hemorrhage is the only other condition that with any frequency will spare the periphery of the lung. This is an unfortunate leukemic individual with thrombocytopenia, and with thrombocytopenia you may start to see spontaneous hemorrhage when the thrombocytes are less than 20,000, more commonly when they are less than 10,000. On the high-resolution CT, it can be very, very confusing. It can be a definite airspace opacity, can be ground glass opacity, and on the high-resolution CT, it may look peripheral as well as central. The other edema, I showed you this in interstitial as well, is the capillary leak. Now, the capillary leak edema is divided into various stages into which we need not go. But acute exudative edema, the alveoli may flood to a very considerable degree, and it may be indistinguishable from classic airspace edema. The big distinguishing mark, of course, is the multitude of air bronchograms. Whenever possible in interpreting chest x-rays, if there is a means to cheat in order to establish a diagnosis, by all means do so. If there is an endotracheal tube in place and the patient is in the appropriate setting, you can be pretty sure that this kind of thing is ARDS, because these are very, very stiff lungs. When there is diffuse opacification in the basis, the etiology becomes very elusive, and one has to have a well-developed differential diagnosis. These two diseases are extraordinarily similar in appearance. One of them, on this side, is aspiration. This, now remember, is not just the fluid that is aspirated, it is the capillary leak that occurs as a result of the fluid. If the fluid that were aspirated were relatively neutral with a pH of about 5, this appearance would take quite a while to develop. If it was a young individual who aspirated a large amount of acid gastric juice, this would appear within a matter of hours, very quickly. This particular situation is someone with pneumococcal pneumonia who is in the process of drifting into ARDS, and therefore with a high probability of death. This must always be considered as an opportunistic infection. It is very uncommon for community-acquired pneumococcal pneumonia to lead to death unless there is an underlying risk factor, and the risk factors you must ask about are the usual ones, AIDS, etc. Don't forget alcohol. Alcohol is a very common cause of pneumococcal or other community-acquired pneumonias. Patchy airspace disease, completely non-specific. An accompanying slide, again, actually from a different patient, so shows a diffuse interstitial disease, very, very opaque, crossed by air bronchograms in this particular case, with a slight lack of what is sometimes called normal parallelism, or a slight failure to taper. These are both bronchoalveolar cancer. There is no way one can look at these and make a diagnosis. One must consider the differential diagnosis that you earlier have of cells, fluid, pus, etc. An example of a community-acquired pneumonia, multilobar. When you see a multilobar inhomogeneous process like this, it could be blood, it could be bronchoalveolar carcinoma, or it could be pneumonia. Which occurs more commonly? Pneumonia occurs more commonly. Which pneumonia is most likely to involve multiple lobes? Legionella is the one that is most likely to do this, and Legionella is the pneumonia that is most likely to progress after the patient has been admitted to hospital and even after appropriate antibiotic therapy has been initiated. And such is an example of it. This is a young girl in her teens with what looks exactly like a pneumonia. It is a diffuse airspace opacity. This is Hodgkin's disease. Again, one must consider the various things that go into producing airspace disease. Non-segmental disease, it can be, as you see, a variety of disorders, infection, hemorrhage, aspirate. I only put blastomycosis in there for semi-nostalgic reasons. We see only a handful of cases a year. We always miss them at the first presentation. And they only need to be kept in mind if you're dealing with a population that is coming to a referral institution, or if you're in a practice that is in a rural area, because this occurs far more commonly in rural areas where people are exposed to the soil than in other individuals. Acute airspace pneumonia can evolve with quite striking rapidity. This is an ostensibly immunologically normal young individual who presented at 1 in the morning with 2 or 3 hours of symptoms, chills, fever, cough, etc. There's a peripheral airspace abnormality at 1 in the morning, and approximately 12 hours later, one can see, this is the slide I showed you earlier, it is extending centrally. It is very uncommon nowadays to find lobar pneumonias. Usually these pneumonias are aborted pharmacologically before the entire lung consolidates. If you find a classic lobar pneumonia, you must strongly suspect that there is an underlying immune abnormality. A non-segmental distribution. This is a version of the BOOP, bronchiolitis obliterans, organizing pneumonia syndrome, which tends to be split off nowadays into cryptogenic organizing pneumonitis, or COP. It is classically peripheral, somewhat more commonly in lower than upper zone, and it is an airspace abnormality with traversing air bronchograms. Clinically, it can also, to a remarkable degree, simulate community-acquired pneumonias. Diseases in the upper zone, uncommon, but radiologically very, very characteristic. This is chronic eosinophilic pneumonia. It's very difficult actually to see now that I look at it on the slide. In the plain film, it is very, very easy to see and very sharply demarcated on the CT examination. If this were acute eosinophilic pneumonia, it would be less homogeneous and less opaque. There is always an upper lobe tendency for it to do that. Segmental disease, one considers those pathogens, oropharyngeal pathogens particularly, aspiration, the products of aspiration. Now, 2 examples of segmental disease. The posterior basal segment of the right lower lobe, not yet homogeneously opacified, on its way to homogeneous opacification. This is a very characteristic appearance of an aspirated infection, or it could be a sterile aspirate. Radiologically, we can only differentiate between sterile and infected aspirate when a cavity forms. Sometimes the presence of an adjacent pleural effusion will be a clue that we are not dealing with a sterile aspirate. Another example where both posterior basal segments are opacified, beginning to involve the lateral basal, obviously clearly posterior because the heart margin is preserved. These actually are both, so far, sterile aspirates. They contain innumerable bacteria which have not yet taken. The nodular airspace diseases, remember, common things commonly occur. When one sees a nodule that looks like a cancer, the probability is that it is a cancer, and it must be so reported. The patois that I tend to use is, this is cancer until the contrary is proven. It is an airspace opacity with indistinct margins. It is in the upper lobe, right upper lobe, the commonest location of primary lung cancer. And this indeed is what it looks like. It is primary lung cancer. Other nodular lung diseases that are related to infection. Again, uncommon, but sometimes a very useful clue. We all know about varicella. Varicella, one can see the classic acinar nodules, which as one progressed downward, are becoming confluent. Most patients whom we see with varicella pneumonia are young, they are female, and an astounding number of them are pregnant. Another example of a nodular pneumonia, which is also in the varicella category, this is HSV2. All the HSV viruses, including varicella, tend to present as nodules. They are focal hemorrhagic bronchopneumonias, and as you know, as they heal, they may progress towards calcification. Two other nodules are both fungi. This is the classic manifestation of Aspergillus in an immunologically deficient individual. The classic central, very opaque infarct with surrounding hemorrhage in the alveolar unit. These are much smaller, much less distinct nodules. These are Candida. Aspergillus produces infarcts by blocking relatively large pulmonary arterioles, therefore the nodule tends to be relatively large, whereas Candida blocks smaller vessels. Candida comes generally from dirty lines. We rarely see Candida anymore. Once in a while it crops up. We commonly see Aspergillus in the immunologically deficient. And again, just for the nostalgia that I expressed earlier, I'm showing you a case of an airspace disease which remarkably simulates lung cancer. And this, of course, is a fairly characteristic manifestation of blastomycosis, which we actually recovered by doing a transbronchial biopsy. And the report came back positive on the morning the patient had already been taken to surgery. Some other examples of airspace disease. One is hemorrhage from a vasculitis, a very patchy, rather nonspecific, quite indistinguishable from bronchoalveolar cancer or multifocal community-acquired pneumonia. And beside it is another example of an airspace disease, which is rather more opaque, quite curiously peripheral in distribution, and that happens to be a bronchoalveolar tumor. Finally, we'll deal with airspace disease that undergoes central necrosis. This is a portable X-ray from the intensive care unit. This, at autopsy, which was performed just a day or two later, had a large central cavity. Using the retrospectoscope very carefully focused, one notes there is a vague central inhomogeneity. On portable X-rays, the air fluid levels will not be visible because these patients are never upright. And in addition, cavitation will only be visible to you when the cavity communicates with the bronchus, permitting air to enter. Classic upper zone airspace opacity with a central cavity. It should be tuberculosis. It should be reported as tuberculosis. It is actually one of the gram-negative infections. Gram-negative infections and anaerobes must always be considered in this situation. Tuberculosis typically looks exactly as the textbook says it should. Post-primary tuberculosis with cranial retraction of the hilum, the cavity, contralateral cavities from air spill, and on CT, characteristically, a very homogeneous opacity. Vasculitis, classically, Wegener's will produce large, very often thick-walled cavities, as one sees here, sometimes containing central debris, which can be necrotic lung or more often thrombus. Aspergillus in AIDS patients, some believe or have reported that it is rare or uncommon, or even that it doesn't occur. We do see it. This is an Aspergillus cavity in a patient with AIDS with a profoundly low CD4 count. And finally, just to remind you, lung cancer may cavitate. Classically, they should be squamous cancers. In reality, they are more often adenocarcinomas, of which this is an example. Thank you very much.
I'd like to just give you an update on some of the things that are going on, and in what I could call computer-assisted diagnosis. And this used to be regarded as an esoteric topic, but now, of course, most of us are reading in soft copy, and these kind of software tools are becoming available, and they're available, in fact, commercially. And I just want to show you some examples of how they can be useful. If you consider how we've progressed from analog to digital radiography, we get more consistent image quality. We have slightly sharper images with consistent density. But generally, these functions have not tremendously impacted the diagnostic accuracy of chest radiography. Certainly getting access to the images locally and over the PACS is important. We can interact with the images, but we haven't really exploited the full potential of digital imaging. So we can consider CAD in the category of enhancement of the image, first of all. And most people don't call this computer-aided diagnosis, but I like to consider it broadly. These are ways that computer applications can help us to extract data from the image. Let's start out with energy subtraction. Then detection programs which can automatically detect nodules, interstitial disease, and so on have been developed. Some of these are available commercially now. We can quantitate, of course, anything that we're able to detect. And finally, we can help to make a specific diagnosis sometimes by integrating the clinical and the imaging material, using, for instance, artificial neural networks, which are self-learning programs. Now, a lot of the motivation for this is that we overlook a lot of information on the chest X-ray. I showed you this morning this scatter of missed lung cancers published by John Austin, showing that the majority of missed lung cancers on a chest X-ray are both in the upper lobes and overlapped by other structures such as bones. Some of these are quite large. So clearly, if we had an opportunity to get the bones out of the image, that would be extremely helpful. And this is what dual energy chest radiography does. And we've been using this routinely in our outpatients since 1996, and second generation units are now becoming available. So we get basically a standard PA image, we get a soft tissue image, we get a bone image, all for the price of one, so to speak, all with a standard exposure, a single shot using the CR imaging system. Clearly, we can see the lungs rather better without the bones in the way, and we can pick up calcifications in the bone image. Let me show you an example of how this can be useful in clinical practice. Here's a patient, and I'm directing your attention to this lung with symptoms of a possible primary lung carcinoma. Several people looked at this image and overlooked the finding, but actually there is something here in the mid-lung which becomes extremely obvious on the soft tissue image when we take the bones out. So merely removing the bones makes the finding more conspicuous by just simplifying the background and reducing the so-called structured noise in the image. Similarly, if we have a nodule, and I showed you this case earlier as an example of calcification. This is a partly calcified nodule in the right costophrenic angle. I think we would suspect it was calcified, but we might not be confident enough to send the patient home. We might want to consider a CT scan. But if this has been obtained with dual energy, we have an opportunity to detect that there is calcium within that nodule, indicated as this dark shadow. And this amount of calcium is pretty well diagnostic of a benign lesion. So we've found that using dual energy routinely obviates the requirement to do a CT scan on many of these benign cases. This is actually a calcified granuloma. Temporal subtraction is a different animal altogether. And let me show you how that would work. And this is something that is not yet quite commercially available, though it is under development, and certainly General Electric have showed examples in their works in progress at the RSNA, and it is actually a commercial product now in Japan and has been used in lung cancer screening programs. So when we're looking at a chest X-ray like this one, it may have a and opacity up at the apex. Pretty nonspecific, could be scarring. If we compare with the previous, and a lot of the time we are comparing with previous, now particularly with digital archives now, there's a higher percentage that we can actually retrieve the previous on. If we are diligent, we can notice that there's been a change on the apex, but that really requires going back and forth with our eyes from one image to the other and happening to pick up that subtle abnormalities. And certainly that's the kind of thing that does get overlooked routinely on the current chest X-ray. What we'd like to be able to do is to take the old image, superimpose it, warp it, and just subtract out everything that has not changed, because if nothing has changed from a year or 2 years ago, we can be pretty sure there's nothing going on. And that's what subtraction does. So we take the previous image, this is a different example, and we actually match each point automatically on the current image and do what's called cross-correlation to get the best match at each point, which involves doing some warping on the previous image. Then we invert the grayscale on the current image so that both cancel out. It never cancels out completely because you've always got some differences in positioning, and this dark area is actually due to a difference in compression of the soft tissues of the chest against the unit as the patient is standing at the chest unit. It's the kind of thing you just can't see on a conventional chest X-ray, but this technique is so sensitive to changes in opacity, you pick up things like this and you learn to interpret them. So in this case that we were looking at with the apical abnormality, it stands out very obviously as a black patch. Again, it lights up almost like a PET scan. Yes, we do have artifact. We have artifact at edges and in the ribs, but these are pretty obviously misregistration, and again, with experience, one is not too bothered by them, but one is directed to this new opacity, which was actually a superior sulcus tumor. So this kind of subtraction technique can make things considerably more obvious. This is a patient who has, again, a somewhat subtle abnormality of the left hilum. You might wonder about pulmonary embolism, actually, in view of what we talked about. And you might wonder about decreased perfusion in that left lower lung. And again, if we do a comparison with the previous, it becomes a lot more obvious. Again, highlights the importance of comparing previous. But again, there's an opportunity to miss this unless we're quite diligent in going back and forth and determining that it's definitely changed. Again, if we subtract these, we end up with an image like this. This is a temporal subtraction. Clearly, there's something black. Now remember, we inverted the current image, so things that are whiter in the current image, meaning denser, are going to be black in the subtraction. So there's some increased opacity in the hilum compared to previous, and there's actually a lighter area, which means that this has become more transparent due to the decreased perfusion. Notice particularly how homogeneous the upper lobes are. So when you see this kind of thing, you can be really sure that nothing has changed there. But this, in fact, was a lung cancer in the hilum. This is a scan which was done about a month later, showing the large mass and the decreased perfusion. So the bottom line is that temporal subtraction makes it pretty hard to miss these little cancers that are so easy to overlook otherwise. Here's an example from Japan, patient being followed with interstitial lung disease. Fairly subtle opacity, hiding as lung cancers tend to do behind the head of the right clavicle, could easily be overlooked. Here's the previous. Yes, there's definitely been a change. Once we look at it, of course, everything is obvious in retrospect. If we do a subtraction, it becomes just extremely obvious that there's been a change. We don't use the subtraction image, of course, to read primarily. We use it as a guide to go back to the current image and decide what's going on there. But we can be sure that there's something new growing there, and this, again, was a primary lung carcinoma. This is a different kind of abnormality, and one of the values of subtraction is with programs being developed for instance, nodule detection. It's not confined to nodules in the lung. It can show anything in the mediastinum or the hilum. This is a patient with sequential chest X-rays over a period of time, and now there's an abnormality in the left hilum. Notice that this is more prominent and it's denser. Again, certainly possible to overlook without a subtraction. When we look at them side by side, again, it's a little more obvious that this cannot be accounted for just by rotation or inflation. And we do a subtraction, and we just see a big black blotch around that hilum, which is the new mass, which was actually a metastasis in this particular case. So again, some misregistration artifact, but it makes the primary value, the primary lesion, much more obvious. And in observer tests, certainly we and others have found that there is a significant improvement in the accuracy of both chest radiologists and non-chest radiologists using temporal subtraction. And indeed, residents, typically less experienced readers, show a bigger improvement with various kinds of image enhancement and CAD, which is as expected, so that residents on this series of cases of lung cancer did better actually than attending chest radiologists when the attendings did not have the subtraction. But the experienced readers can still show a significant advantage using these techniques. And there are multiple other publications now in the literature, particularly from Japan, showing that this kind of technique is clinically useful. If you're not in a soft copy mode, it really is not practical. And this is just one more reason to move to soft copy as these techniques are being developed. Now I've shown you energy and temporal subtraction, so you might say, if these are both available next year, which should you get? Well, they're not mutually exclusive. We have energy subtraction, and we can do temporal subtraction under an IRB for research. Here's a patient in January a year ago showing bilateral apical opacities, pretty nonspecific, could be scars. Which should we do, temporal or energy subtraction? Well, here's the previous chest X-ray. Several years ago, I think you'd agree that there's some degree of change. There might have been something faint there, but it does look like there's a change in probably both apices. Here's the energy subtraction of the current radiograph, and you can now more clearly see that there's an abnormal soft tissue opacity at both apices that isn't accounted for by overlying bone. Here's a temporal subtraction that nicely shows the new areas, which are these growing lesions in both apices, some other little areas too. But this is extremely obvious now that something is going on. On the other hand, since we had an energy subtraction on both exams, what if we combine them and just subtract those soft tissue images without the bones? And now it looks even cleaner, and now we just have got these big opacities that are the new lesions and relatively little artifact now from the bones. And in fact, if we play with this and window it to an extreme degree and do a little filtering, we end up with this, which I just show as an extreme example of how you can simplify the complex information in the chest X-ray by a little basic image processing. The other little speck is the left lead marker, by the way. So this is becoming as easy to look at as a PET scan, you might say. CT scan confirms these were actually bilateral synchronous primary lung carcinomas. Let me show you a little bit about tomosynthesis, a technique largely developed by Jim Dobbins and others at Duke University, and I show these slides with their permission. This is a technique for obtaining a sequence of rapid exposures, either in standing or lying position, to create essentially tomographic sections through the patient. This can be done in a single breath hold and with a relatively small radiation exposure. This is a phantom image that they achieved using this technique, and one can actually rotate this image in 3 dimensions and can clearly show depth information in this. Okay, let's move on quickly to nodule detection and other kinds of computer-aided diagnosis. This has been a long-standing project at the University of Chicago and elsewhere to automatically detect nodules in chest X-rays. And it's approaching maturity, but it's a very difficult task to achieve automatically. This is a faint nodule in the right upper lobe. We do linear filtering, we extract the signal, we do a lot of tests on the actual nature of the signal to try and distinguish false positives from true positives. It would come under the heading of feature analysis. And finally, try to extract the true nodules as distinct from the artifacts and the summation effects. So this particular nodule is detected by this program without any false positives, and I think you'll agree that's a pretty subtle nodule, and this kind of a program can be helpful. The practical problem is that, as in this case, it's also a right upper lobe nodule, but it's a different case. there are usually false positives, because to be sensitive enough to detect small nodules, the threshold has to be set at such a level that other normal structures tend to be picked up. And there's a lot of question about how many false positives radiologists can tolerate. But certainly, using selected cases, normals and ones with nodules, we've shown that you can see a large improvement in radiologists' ability, even non-radiologists' ability, to detect pulmonary nodules in chest X-rays. And a commercial system is now available that was developed by a company called DES, now marketed by General Electric Medical Systems, that can detect nodules in digital chest radiographs, and this has shown a significant improvement in, again, observer testing situations. Now, since there are several of these systems probably going to be on the market, I'll just say a word about how you might want to evaluate a computer-aided diagnostic system. How do you compare them? How do you evaluate numbers like sensitivity and specificity? If one company says its sensitivity is better than another, what does that mean? This patient has got a number of pulmonary nodules. You may not notice, but there's one here, there's one in the upper lobe, and these are, in fact, all of the nodules that are present in this chest radiograph. If we have a hypothetical computer-aided diagnostic system that puts circles around every detected nodule, here is the result from that hypothetical system. It's missed all of the nodules. It's a sensitivity of 0, and it's a false positive rate of 6 per image, if this is an average image. Here's another hypothetical system. Now the circles are larger, so they've encompassed most of the nodules. We've now got 75% sensitivity and 3 false positives. This is actually the same program, just putting larger circles on the image. And once you're up to around 5 or 6 false positives, you can cover a lot of real estate with your arrows and your circles. So be careful when people quote numbers like sensitivity. Again, the difference just in how the positives are indicated. Extreme example, here's 100% sensitivity. Okay, so sensitivity is totally meaningless without specificity. The size of the markers makes a difference, and how you even define true positive, false positive. And this is a big issue with CT scan, CAD systems. So both are going to vary according to the cases used, and this is one of the big issues that now we're trying to address in radiology in general, and especially in chest, is there are no really comprehensive publicly available databases so that all of the companies can test their systems on the same cases. If one company is using easy cases, another is using difficult cases, the sensitivity specificity are going to depend on those cases. And a company that advertises, say, 60% sensitivity for nodule detection might actually have a much better system than one that advertises 90% sensitivity. It's just that they happen to be using different cases. And until we have a database that everyone can share, this is going to continue to be the case. Again, these systems can work together. So this is the case I showed you earlier with the primary carcinomas at the apices. This is an actual run from a CAD program. It's got 3 false positives and has not detected the nodules. On the other hand, if we use the energy subtracted image and adapt the program, it has picked up at least one of the carcinomas. So there's potential for these systems to work in conjunction with energy subtraction.